We're here today to talk about your first week after your joint replacement, especially for knees, which can be quite more painful in the first couple of days, in the first few weeks. But it applies to any surgery that you have that relates to a joint replacement. So I'm going to bring a new perspective of understanding your first week. It's very important to understand what your body's going through because the information that is shared and given is very generic, is for the mass, and it's really the information is created in a way to create limitations and parameters to make sure that you achieve the best outcome. However, separating the first week and the first 2 weeks of a post-operative compared to the rehabilitation that you are then given to progress with your movement and strength are very different, a completely different advice. And I'm sure you go through this advice when you come out of hospital. But by that time, with everything that is going on, you just came out of anesthetics, it's a whole change of routine, there's a lot of information. I'm sure that a few things gets forgotten and mixed up, and it becomes more difficult to understand. So here I'm bringing in this free workshop this information because I've been seeing quite a lot of patients in person at their homes on that first or second week of a post-operational of a joint replacement. And what I'm seeing is that lack of understanding what's happening, what they're going through in that first week. And I think it's very important to put into perspective because you are the one having to deal with the new joint, the new way of being, caring for it, making sure you understand and feel confident of what to do and not to do and when. Because the first week is very different than week 6. The second week is very different than week 10. But the advice that we're given is an advice that is more generalized for later weeks after the operation. And that very first few days after you come out of hospital can be very daunting, can be very scary, can be very, it can bring a lot of confusion. So I'm here to clarify. At the end, we're going to have a Q&A. And I would like you to be able to add even your questions if you are watching on YouTube. Add more questions because I would like to bring more material like this. It'd be very interesting. So I'm going to put a little slide, and it's really just to help me and help you with some visuals to follow through. So if you are at any stage after your operation, not just week 1, but week 2, 3, 4, 5, 6. This can be very important, okay? Because you could still be navigating with some signs and symptoms in the area of the operation that you might want to have a quick look, speak to your GP in case that's still happening. So I'm going to share the screen. There you go. Brilliant. So here we are. This is the beginning of our very quickly workshop. Easy to understand information, and it's something that it's going to help you immensely if you are anywhere after that first week or after that day post-operative for joint replacement. So this is the idea, is to really think about the early healing stages. Yeah. It's very traditional and it's very strong taboo to hear about no pain, no gain. I always share this and try to break it down, this taboo, because it can be very damaging. There is definitely a place for no pain, no gain. But that no pain, no gain should come without any guilt, any blame, any shame. That no pain, no gain comes at a point when you are ready for no pain, no gain. That pain from putting the effort, from exercising strong and using weights, and it's a different type of pain. The pain that we are dealing with right now, negotiating right now, is a pain from the healing process. Healing process is an inflammatory process. And I need you to understand the inflammatory process well enough to understand that this is a good thing. But the pain that we are experiencing during that process can be damaging if we are pushing through. So this is the rethinking of the early stages of healing so that you have a much smoother recovery through the next few weeks into your phase where you actually are pushing through exercises with a different type of pain. So no pain, no gain is basically a myth for certain phases of your recovery. Pushing into sharp pain can cause the muscle to go into a protective mechanism. And that protective mechanism looks like muscle tension, muscle cramping, muscle pain, muscle stiffness. Yeah, that stiffness that you feel after moving, after being resting for a bit. And if you are moving, if you stiff, that is a protective mechanism of the muscle. That means that an hour before, 2 hours before, you've done something a bit too much for that tissue, and that tissue now gone into protective muscle state, muscle guarding. So that means you are increasing the tissue trauma. And how are we increasing the tissue trauma through that week one is what you need to understand, because we need to avoid that tissue trauma. Your tissue has gone through immense trauma through that operation. And right now, your tissue is going through an inflammatory process to heal the tissue, to allow that to mend together so that eventually you can start pushing. Forcing the joint through movement or using any type of resistance at this stage, it will only create more pain. You're going to end up going into pains, spikes, and basically, we're not respecting our body. We're not respecting the phase that we're in. And this is why I bring the understanding of this specific phase. And pain is something that needs to be there. It's a signal. It's trying to help us understand at what stage of the inflammatory management that we are. And respecting that pain threshold in the beginning will allow your tissue to repair easier. Avoiding those flare-ups, avoiding those very stiff and painful moments with your joint. So once we go through the inflammation process, which I have another video specifically for that, it's a bit more detail. It's a lot of information to put it all in here. But basically, we're talking about the tissue that is going through swelling, heat, so it feels warm when you touch, and that pain spike, that pain trigger. In phase 1 and 2, like week 1 and 2, we are prioritizing to facilitate the inflammatory process so that you don't fall in a repetitive inflammatory loop. When you fall into the repetitive inflammatory loop, you will be experiencing swelling on, swelling off, heat on, heat off, pain on, pain off. And that cycle of that spike is what we're trying to avoid, because inflammation is supposed to work in a very gentle, wavy line. If we are spiking, that means we are aggravating the situation. We're causing more swelling, we're causing more inflammation and heat. We are then causing more pain. So the swelling is your priority when you come out of hospital. You might be asking about ice. Yes, if your tissue, your skin feels warm, you will need to put ice. But I also offer the option to use a cold compress. When you are shocking the tissue all the time, it's hot and then it ice, hot and it ice, hot and it ice. You can create scar tissue around the area. But why are we going from heat to ice, heat to ice? It's because we're doing something that is causing the inflammation to spike. Therefore, it causes the heat, and then we have to then use the ice. So I say to patients, ice, yeah, in the first couple of days, but then after that, cold compress, but also to look what are we doing, which you understand halfway through this workshop, what are we doing that is then causing the spike of the tissue, the inflammatory loop. So when you're having those up and down swelling, heat and pain, that means we're doing something that's causing these spikes. And here is the perspective that I want you to understand is what are we doing to cause that and what can we do to avoid? So we're not in a spike wave, we are more in a lower wave of inflammatory healing, okay? And here you can see this exercise with an elastic band. And yes, there will be a time for that, but there is a huge difference. There's a huge difference between mobility and exercise. In the first week, we will be mobilizing the joint. We'll be moving the knee into flexion, into bending, into a straight knee. We'll be walking on it a little bit. We'll be then going to the toilet, and then when you go to the toilet, you're squatting. When you go sit down on a sofa, you're squatting. So you're doing all of those mobility movements all the time throughout the whole day. Exercises means that we are loading the muscle with weight. We are creating resistance with elastic band, that we are forcing the knee into the bending, we're forcing the knee into the straightening. And that's all designed to build strength. However, when you are mobilizing, you are also creating a way to drain the swelling. Yeah, when the muscles are mobilizing, they are squeezing, contracting very gently. And that creates this nice, gentle drainage force from the tissue into the lymph nodes to be removed by the body. When we are squeezing the muscle beyond its capacity to squeeze, because it first has to squeeze against a lot of fluid, it doesn't have the power to do that. So then you are fatiguing the muscle even further, which then you break down muscle fibers, and it's not in the space and time to break down muscle fibers. And then, of course, you're creating scar tissue, more pain, more swelling, more heat. So there's a time to introduce the exercises which are related to loading, resistance, and forcing. And also that also is going to have the time to be more gradual. But right now, in your first week, second week, we're talking about mobility, gentle, non-loading, fluid movement type of mobility. And we're doing this to flush this swelling, to circulate joint through fluid through the joint, fluid through the muscles, to remove, because the muscles there is cleaning up all this inflammation. So what we want to do is, can we squeeze all the debris, all the chemicals that the inflammation is producing, and squeeze it out, flush and drain, right? And this is how we get rid of the swelling. What we don't want is the swelling, for you to work through the swelling, and then the swelling goes down to the ankle, and then it gets stuck there. And I'll explain why and how to avoid this. And that's what I mean. It's just making sure that we're not falling into the exercise so quickly into your first phase of your rehabilitation. So basically, I talk about with patients the little and often versus prolonged activity at this stage. And I call it the 10-20-30. And I'll explain in detail what that is. But what I want to come through is when you decide to have a joint replaced, you have decided to commit to the rehabilitation. That's very strongly discussed with the patient, consultant, physiotherapist. At the time you decide, they explain all the efforts you're going to need to put through, all the commitment, and what is needed to actually get a good response, right? Because a surgery it's an amazing high technology these days. It works really well, but it has to come with the other side of the rehabilitation, which is the patient commitment. And that can cause quite a lot of fear in people because they will think, oh, if I don't do this, my knee won't be good. And I went through all this, pay all this money. Some people go or waited so long, sometimes a couple of years to get that knee done, to get rid of the pain, be able to be functional, be able to be not as debilitated as you were when you were in pain. And then you think, well, how much is too much? Yeah, how little is too little? And of course, the advice comes on a very generic parameters, right? Because they want everyone to do well. But I think that advice misses this perspective of this early stages of healing for your tissue, for your muscles. It's been cut through, your bone is being worked through, shoved off, and new prosthesis put it in it, and everything works fine. But how can we make it work long term? And in the first phase, we want to avoid that crash cycle that we spoke about before, the inflammatory loop, where the inflammation doesn't finish, it stays inflamed the whole time. We want to do that by not exercising loads all at once and then being so tired and also in so much pain, because the first week, if you have had a general anesthetic, you will possibly experience some fatigue, right? Some tiredness. And to have to exercise, 15, 20 minutes and then be shattered and then eventually be in so much pain that you cannot move, that you have to rest, and that rest is prolonged. And then when you come out of rest and you're trying to move, you then experience that severe stiffness. And besides the swelling spikes. And this is what we're trying to avoid. We want to keep our cycles more gentle, more consistent, more constant, rather than all out and then stop and surrender to the pain, to the swelling. And, then you're taking more pain relief. And yes, you want to keep your pain relief regular for the first few weeks until you're sure that you are dealing with manageable pain. However, even through this micro movement strategy I'm going to explain, pain relief is still, needed. You are still dealing with pain from the inflammation, pain from the surgery. What we don't want is the spikes in pain from the tissue being damaged because we're pushing through. That's what we're trying to avoid. So the 10-20-30 is 10-20-30 is an hour, right? So I would like you to look at it this way. So 10 minutes of mobility, gentle movements. You can do a variety of different mobilities. I can share on a one-to-one more advice, more information of these movements. They're very easy to explain over the virtual call. However, it just would take a long time for me to explain. But there are mobility exercises. There's no elastic band involved. There's no high levels of repetition involved. And it's every time that you go to the toilet, that you go to the kitchen to make a cup of tea, that you perhaps go to the front, the back door and look at the garden. Every time you're walking around, you are doing mobility. You are doing physiotherapy. So I count those movements around the house as your 10 minutes of mobility. When you mobilize your muscles, you are doing that very gentle, smooth, soothing contractions that's happening while you're moving. You don't have to do that with your hands, but I'm just representing the muscle contraction that happens inside the body. and then that squeezes fluid from the area. When that movement stops, the lymph nodes are going to try to kind of flush that. So this is when we need to elevate the leg. When you elevate, you cushion the leg, you support the whole leg, and you elevate with the knee slightly higher than your hip or your heart. Okay, so lying down on a sofa with the leg above the sofa arm with the knee supported underneath. Or in bed, if you're lying flat, you can put the leg over a pillow. And I will talk about the leg over the pillow in a minute. And then the next 30 minutes is your moment that you can rest, you can sit down, you can perhaps go on a computer if you have work to do. Yeah, that's the moment that you don't need to worry about moving so much, but you can then put your leg down. You might be able to even do some ankle movements during that time, or if you're sitting, you can do some straightening the leg and bending, very gentle, but it won't be as consistent as your first 10 minutes of mobility. During those 20 minutes of leg elevation, you'll also be able to put your ice or your cold compress while it's elevated. However, if you do put the ice during those 20 minutes, please keep it elevated for another 5, just so it flushes a bit more, because the ice enhances the drainage of the swelling. And remember, those 30 minutes, those are the moments that you are resting, you are sitting, you perhaps going to the toilet. Yeah, gentle mobility. And if you keep going there for the wake hours of the day, it feels like a lot, right? But if you time maybe the toilet or the cup of tea or the lunch or, those movements on those 10 minutes, then you are getting up every 10 minutes of the hour. However, those 20 minutes are also very important, because every movement that we create an opportunity for drainage. So those 20 minutes are there for you to drain that knee. If you are working from home and you're doing that, I would say that your 30 minutes is your 30 minutes. So you perhaps sit on the computer and then get some work done, right? And this is because that is the commitment to make the knee work, to make the operation work. But you're not sacrificing the tissue by pushing through, by working too hard. You're not sacrificing then your sanity, because to go through these pain spikes all the time can also cause quite a lot of overwhelm and, fatigue, tiredness. Working with pain can be very tiring. So pay attention to these signs and symptoms, fatigue, headaches, you want to be hydrated, and, is the swelling on and off, going to the ankle, coming back to the knee. You want that flushing always upwards from the ankle to the knee, from the knee to the groin. That's why the leg needs to be elevated. And now we're going to do a bit of clinical truth and rules, right? Just to clarify everything. We want to make sure that some of the information that we get, that we debunk a little bit, not because they're wrong, but because they're not complete. And this is what we're going to go through. So, placing the pillow under the knee is a mass advice, strictly, absolutely no. It's an absolute no. I don't believe that's an absolute no, but I understand the reason why it's given that way, because I have worked in the public health, and I understand that if, by the time you see a patient within 2 or 3 weeks, if they have spent a lot of time with the knee over the pillow, there's a greater chance that it won't go straight as much as you would like. However, when you're looking at that 10, 20, 30, right? When you are elevating the leg and you have nothing underneath the knee, your muscles are not ready to support the weight of the knee. And that can compress the muscles in the joint a bit too much, to the point that when you come out of that position, it'll be extremely, extremely painful. When you are elevating that leg, you're okay to put the pillow right underneath the knee. You're also okay to then, in another 5 minutes, move it a little bit further towards the calf, and then move it a little bit back towards the back of your thigh. Yeah. And it's about changing the position later and often. When you go to those 30 minutes, you're not necessarily resting the leg on the stool for the full 30 minutes. You can, but on those 30 minutes, you can change positions throughout those 30 minutes. You could be on a sofa, you could be on a chair, you could be on a bed, you could be walking, you could be going to the toilet. And if you are resting your leg on the stool, yes, it's okay to put a pillow under the knee, but I would not give it more than 5 minutes. Okay. And only if you are also allowing the knee to rest without the pillow. Resting the knee without the pillow, if you're sitting in your bed, so if you're sitting upright with your legs straight, that's perfect. Yeah. The bed is cushioned, the knee is supported, but it's going straight. Gravity is going to work on the top of the knee, and eventually after a few minutes you will get much straighter than the first second when you got in the bed. And like I was saying, elevation is very crucial to reducing swelling, but it must be with support of the leg for the entire leg. If you're lying on the sofa, let's say, and then you put your leg on the arm of the sofa, that big gap behind the knee, between the knee and the sofa, I would cushion that. I would fully cushion the whole back of the leg. If you're lying down on your bed, flat, and you have a cushion on your knee, I would elevate the leg straight and cushion the whole leg. So the pillows under the ankle would be higher than the pillows under the thigh. Yeah. But it would be throughout the whole leg. And then that's how you get the drainage. Because if you have flexion when you're elevating, like bended knee, the fluid struggles to go through the crease of the flexion of the knee, right? So it gets stuck there. So by the time you get up, the fluid is going to come down to the ankle. So yes, it's important to have a full knee straight, but I wouldn't force the extension. When I say forcing, if you don't have a knee underneath, the knee goes forced into extension. And this is where it increases tension in the muscles, because the muscles are protecting the joint. And then the drainage will stop anyway. So pillow under the knee, yes, okay. Only when you are doing the elevation job, okay? But fully support the whole leg. Would you sleep with a pillow under the knee? No. Or can you have it for 5 minutes before you then start to straighten it? Yes, you could. Okay. And when it's safe to progress. And then we're talking about progress to those exercises where you are using resistance, where you are forcing the bending, where you're forcing the straight knee, where you are creating loading. And remember, when you're doing mobility exercises, your first movement might feel very stiff, but by the time you do 10 or any number, yeah, I'm just giving a number, you will notice that your movement improves by the end of that number that you chose to do. It could be 6, 10, 15 repetitions. You will notice a massive increase. And every time that you start a movement again in the next hour, you're going to be on a greater range and finish with a better range. Next time, more improved range, and finish with a greater range. If you are creating that gradual progression, that's brilliant. You're already doing a lot of the gradual range of movement progression while you're still in that first week or two of your early stage healing. But how to progress then to the, the exercise where you are using the rubber bands, it's pretty much after the doctor or the consultant takes the stitches out or the strip out of the knee or the joint. Yeah. When those surgical stitches come off, when the strip closures have sealed the skin, when the glue have sealed the skin, depending which one has been put on your skin, on your wound. That's when it's safe to then start pushing a little bit. Okay. When your swelling baseline has dropped, when the swelling is not spiking, when your knee looks a lot less swollen than you have known for the last week or two, your tissue then is ready to progress for that increased, a little bit more forced range of motion. And the gradual strength progression comes along that side. And it's still gradual. Yeah. And we got to look at the pain baseline. Even through that gradual strength progression, we're not working through pain that is very excruciating or uncomfortable. And also, the first few days that you start doing your gradual strength progression, you will notice how much is too much. How much have I done now? You might not know how much is too much. You will know when you start later on. If the pain increase, if at night you're experiencing more pain than the nights before, and you think, why is it painful now? Look at what you've done the day before, the day of, because the increase of activity or increase of loading is what sometimes can trigger that pain. We want to understand how much is too much. And too much is when you are throbbing at night, you've probably done too much, so go back. And then the next day, maybe cut down by 5% of what you've done. Yeah, not a lot, but just by 5%. And you'll be able to judge how much is too much for you. And going back. Okay. So basically, week 1, week 2, you don't need to push through the pain to achieve a successful joint replacement recovery. Even through you strengthening, there is a certain type of pain as well that you want to avoid, right? There is the no pain, no gain phase. Absolutely, yes. But I want you to get there ready for it. Not after you push so hard in your early stages of recovery, and then your muscles have built up a protective mechanism that makes the next stage even harder. And that's all this early stage is about, making sure that you're not building the wrong mechanism for it. If you want any more clarity, I have a booking schedule, and quite a few people have been booking even just a virtual call to go over these questions, to go over this advice, for clarification, for confidence. And the sooner the better, because it's the early stages that makes a big difference. So if you want to book a virtual call, there's a link below. And here are some of the questions that I quite often get from patients. I'm going to answer them one by one. So how long should I rest my leg? I would like to go back to the 10, 20, 30. You will be definitely elevating those 20 minutes if you have done the mobility work for the good 10 minutes. Okay. And the 10 minutes does not have to be a steady 10 minutes. You're going to move, you're going to rest, you're going to do a different movement, you're going to rest, take a break, and then do another movement. But then when you elevate it, it's a good 20 minutes. If you decide to ice at the same time, that's brilliant. Put the ice for 10 or keep it elevated for 20 of that period. And then the 30 minutes is a mixture. The 30 minutes is you changing position. Perhaps you're using the toilet. Perhaps you need to go in the kitchen and make lunch or a cup of tea. Perhaps you're getting to the door, somebody going to the door. You can't match that into your 30 minutes, but this is what I mean. Is where you need to do things, where you're pottering about, where you're just doing gentle walk in a house, going from room to room. Everything's physiotherapy. Everything in your day-to-day is physiotherapy. So resting the leg, if you've done the work, elevation is rest. If you are fatigued, tired, and your pain is increasing, I would put your leg into elevation and rest. Okay. How many repetitions of the movement exercise should I do? I'm only going to talk about this first phase, the week 1 or 2, because I only want to talk about mobility. If you are doing the mobility movement, I want you to pay attention how far, let's say if you do just the bending and straightening of the leg, you'll be sitting down on the bed, upright, legs straight, and you have a little rope around your foot, and you're just kind of assisting the leg to bend a little bit and then straightening. You're not forcing, you're just helping. Okay. And I want you to pay attention how far you can bend before pain, just tension, and then straighten. And then do a few more repetitions and count. And notice if you can bend a bit further. I want you to finish every mobility exercise, every mobility movement that you do, always with more range than when you started. If that took you 2 or 3 repetitions, great. Just keep going a bit more. If that took you 10 or 15 repetitions, then you know you need to work on that one a bit more often. Okay? Should I ice my leg and for how long? So ice, again, just to highlight, a bag of ice is great, especially in the first few days. 15-20 minutes is enough. If you have ice during the period of elevation, you need to extend the elevation for at least another 5 minutes after the ice comes off at 15-20 minutes. And the reason is because when the ice comes off and the tissue starts to get back to normal temperature, you are draining even more. So the ice enhances the drainage, but allow your leg to stay elevated after the ice come off, because otherwise it will flush down to the ankle. Okay, and then we're back to square one. So should I ice my leg and for how long? Ice can go for 15-20 minutes, and then you elevate for another 5-10 minutes. And if you think that you are spiking with that heat in the tissue all the time, I would then try to slow down your movements, maybe not work with so much pain, and also use cold compress so that you can cool it down more often, but not shock the tissue with the ice too often. Can I go for a walk? Yes. Pottering around the house. Maybe if you have a flat surface, backyard, front yard, front drive, you can do that. Try to avoid inclines, too much stairs, down hills or up hills. But flat surface, try to avoid uneven ground. And make sure you have your aid, whether you are on a Zimmer frame, whether you are on crutches, and make sure you always have 2 crutches, especially in the first 2 weeks. May have someone with you to walk with you if you're outside. Watch your step and then just, enjoy the sunshine. I struggle getting out of bed. I lack the strength to move my leg up. Can I get help? Absolutely, yes. You guide the person if there's a person that's going to help. Where to hold the knee, how much to lift, you guide the person. You know how you're feeling, you guide the person. If you need to do it by yourself, you can use a dressing gown belt. Okay, you get the dressing gown belt and make a loop on one end. You hook the loop through your foot, and then you can use that to lift the leg into the bed or down. And you can definitely help. You're not missing out on any progression. In fact, you are perhaps saving you too much effort to the point that the tissues scream, and then by the time you get in bed, it's been too much already. So yes, you can help, at least for the first week or 2. I try to avoid pain relief to measure my pain, but then later I'm in too much pain and I must rest for an hour. Is this correct? So it is important that you stay on your pain relief medication that's being prescribed. And the reason is to control the pain levels. We don't want to be spiking, because the spiking will stop you from moving. Spiking pain will stop you from mobilizing. Yeah, so increases the need to rest, which then you're not moving. And also, you don't want to really know how much pain you're actually feeling, because really you shouldn't be working to that high pain threshold. And this is why the early stage is important, to understand your pain threshold. Understand how much pain is too much. And if you're not sure, what I ask patients is, right, we're going to rate your mobility pain from 0 to 5. 5 is too much pain. We're going to work between 0 and 3, and that's it. You work to that with pain relief in your system or not. You work to 3. Yeah. When there is too much pain and you must rest for an hour, I want you to rate that. Is it a 5? Because if it is a 5, then you're moving too far, too fast. Maybe you're loading the knee. Maybe, maybe you need your pain relief. You want to keep the pain under control. I went for a walk and then became very stiff and painful to move afterwards. What happened? So, how long is the walk? You need to ask. Yeah. How long was that walk? Was it 15 minutes? Was it 10 minutes? Was it half an hour? Because if the tissue isn't ready, because the tissue needs to build endurance, even for mobility, even for movement, for weight bearing, for sustaining your body weight. Yeah, in the first few days, you take more pressure on the other leg, but then every day you take a little bit more pressure on the leg that's being operated. So if you feel that you're getting very stiff after you go for a walk, perhaps the walk is a bit too much, or what I would like you to experiment is, after the walk, elevate the leg, because the walk squeezes the muscles and then contracts the muscles, and the muscles squeeze the fluids, and the fluids will try to shift, but if you sit down, it will get stuck back in the knee, so the knee can get swollen, stiff, and painful. So elevate the leg after the walk, okay? And maybe realize if the walk was uneven, if you had an incline or a decline, or was it too far? And make sure that you're walking with full support. In the house, we can walk with one crutch, and then the other hand will be around the furniture. But if you, to be very careful, I would use the 2 crutches at all times, even outdoors, okay? That keeps people away from you. They understand that you need more space. They walk around you more. And it's just a way of protecting your gait, your walking. Do I need to continue wearing the stockings? The sock. I wrote that wrong. That the hospital provided. Yes, you do. Whatever period, I think they're talking about 6 weeks these days. Whatever period, yes. Patients are being discharged much, much sooner from hospitals. So the socks are there to protect you from any possible problems with circulation, DVT. And if you're not under their care for a bit longer and you're going home a bit quicker, they want to make sure there is something there for to support you. Should I use just one crutch now that I feel more confident walking? You may, of course, but what I would suggest, just like I mentioned before, if you're out and about, I would always take 2, okay? As you walk with crutches, your space is widened, and that stops people from shoulder barging by accident, by getting in your way, and a lot of the times, if you're walking in busy places, we have to do a lot of stop and go to let people go and things like that. And those little jarring moments can cause a bit of pain in the knee. So it's best that you have the crutch, because then you can keep a steady pace. Yeah, people get out of your way and you walk through at a steady pace. So it's more for safety. And if you have any questions, feel free to add in comments. I would love to know your questions and I can come back with more information. But right now, I think that's it. Thank you so much for being here, for being part of this workshop. I look forward to bringing more information, more advice in other areas. So feel free to put on requests. Thank you.